Okay. I think appears to be recording now. Okay, so I'm Preston Schneider. I'm one of the general cardiologists here at Bozeman Health. We'll talk a little bit about what you can do to control your risk of heart attack and stroke. It's a question that I get asked often in clinic, although usually by the time they get to our office, there's already been some sort of event. And so it's a little bit different once you already have known heart disease. But in the absence of known heart disease, there are certainly things that you can do and that can reduce your risk of heart attack and stroke. So first of all, terminology. And I want to make sure, because it is the end of the day for me, I will try to use the lay terms as much as I can. But if I say things like MI or myocardial infarction, that means a heart attack. I'll say statin drugs probably, and that includes all the lipid-lowering drugs, so rosuvastatin, which is Crestor, atorvastatin, which is Lipitor, pravastatin, which is Pravachol, and there are many others. But if it ends in statin, it's probably a cholesterol-lowering medication, and they all kind of go together in a class. If I say cerebrovascular accident or CVA, I'm meaning stroke. If I say ischemia, that's probably the one I'm most likely to slip on. That is meaning inadequate blood supply to some portion of tissue. And then cardiovascular disease, and that's kind of a blanket term, but it's really, cardiovascular disease is plaque or narrowing of the arteries in the heart, in the brain, or it can be in peripheral areas as well, like in the legs and the feet. So those are the basic terms, and I'll try to be clear, but okay, so the 5 things that I'm most commonly asked about when I'm seeing patients in terms of what can be done to reduce risk. So diet, what about diet? What about exercise? What about weight loss? Do I need medications? And then what is my risk? So let's talk about diet first. So when cardiologists in particular, and endocrinologists as well, usually, when we talk about diet, what we're really meaning is pattern of eating. I'm not meaning a weight loss plan. I'm not talking about the South Beach diet. I'm not talking about, the Atkins diet. What I'm talking about is a pattern of eating, and so it's a more inclusive concept. It's not specifically for weight loss. So when I'm speaking about diet with patients, what I'm talking about is, what pattern of eating has been shown to reduce risk. And there really are only 2 patterns of eating that have been shown to reduce risk. The most widely known and the most well studied is the Mediterranean diet, in particular low sodium Mediterranean diet, and then the low sodium DASH diet. DASH stands for Dietary Approach to Stop Hypertension. And it was a very specific diet that was developed for a study, and it's a much more tightly defined diet than the Mediterranean diet. So the Mediterranean pattern of eating, right? It has been a little bit tough to study this diet because there is no uniform definition of what is the Mediterranean diet. It's the pattern of eating that happens in countries around the Mediterranean Sea. And this is generally higher in fruits, particularly fresh fruits, higher in vegetables, particularly root vegetables and green varieties, high in whole grains, so cereals, breads, rice, or pasta, and higher in fatty fish, and particularly fish that are rich in omega-3 fatty acids. And it's really lower in red meat. In fact, red meat in most of these patterns is almost non-existent. When we say higher in fatty fish, it's higher in fish as compared to like a traditional American diet. It is still not high in protein calories as we would generally consider it in an American diet. Most of these patterns that were studied, there's really no more than 1/3 of the calories are coming from meat-based protein. Additionally, in the Mediterranean pattern, lower fat or fat-free dairy products were are generally used in preference to higher fat dairy food. And then the emphasis on oils rather than butter. So olive oil primarily, but also could be canola oil, nuts, and then so nut oils, so walnut oil, almond oil, hazelnut, or margarines that are blended with rapeseed or flaxseed oils instead of butter. Additionally, for the most recent dietary guidelines that the American Heart Association put out, they looked at how much fat was in each of these patterns, how much saturated fat, how much fiber, and really kind of moderate amount of total fat. It's not truly, it's not as restrictive in terms of low fat as some of the other dietary patterns, but it's 32 to 35% of total calories, but relatively low in saturated fat. Only 9 to 10% of the total calories coming from saturated fats. Fairly high fiber. And then particularly high in omega-3 fatty acids. And that seems to be a key component. All right. So then the other eating pattern that has been shown to reduce cardiovascular risk is the DASH pattern. Again, that stands for the Dietary Approach to Stop Hypertension. This was developed for an American study, so it's more rooted in a traditional American diet, but sort of rearranged the proportions of what goes into it. So basically, low in sweets, low in sugar sweetened beverages, low in red meat, low saturated fat, low total fat, and low cholesterol. And you'll notice already there's a lot of similarities between the actual content of the Mediterranean diet and the actual content of the DASH diet. The DASH pattern, again, high in vegetables, high in fruits, low-fat dairy, whole grains, more emphasis on poultry and fish and nuts for protein sources than red meat. And so, again, it's more rooted in an American style of eating, but it has significantly rearranged the proportions. And there are a lot of resources on the internet about the DASH diet that are relatively easy to find. Nutrient-wise, for the DASH pattern, it tends to be just higher than a standard American. And these are all, when I say higher in, lower in, as compared to sort of like a traditional American style of eating. So it's a little bit higher in potassium, magnesium, calcium, and particularly non-meat-based protein, and then fiber. And those things, again, are significantly different than the standard American diet. Okay, so that's diet, and we'll get back and we'll have I've left plenty of time for questions at the end because that's usually where, because there are always specifics that people want to talk about. So, exercise. What should we do in terms of exercise? And I find that there's always a fair bit of confusion because there is conflicting advice about what to do for exercise. And the importance is that there is a significant difference between exercise for performance training and exercise for cardiovascular health. There are two related concepts, but they really have different goals and they really have different ways to get there. So exercise, we define it as moderate to vigorous physical activity. So what I try to tell patients is this is a brisk walk. This is walking at probably 90% of as fast as you can walk. So you're walking pretty fast. But it's any activity that elevates your heart rate and makes you breathe hard. For a 50-year-old, I would say your target heart rate for this would be 120 to 130 beats per minute. And that's modified by age because as we age, our predicted maximum heart rate goes down, and so then the 65th to 75th percentile of that also goes down. But that's, around between 110 to 120 is pretty good for almost everybody. Younger you are, the higher the heart rate is. But the thing that most of the time I find when I'm talking to patients is is an issue is that we're not exercising long enough at that high a heart rate, and we're not doing it enough times per week. A 40-minute brisk walk is a fair amount of exercise. By the end of that, you may feel fairly fatigued. I mean, everybody's different, but, and 4 to 5 days per week. I'll often have patients that come in and say, yeah, every weekend I go for a walk. Well, that's great, and that's better than 0, but it does need to be a little bit more than that if we're trying to optimize cardiovascular risk factors. So again, training for cardiovascular health is much different than training for performance. For cardiovascular health, we're going to emphasize longer, sustained elevation of heart rate, but not as high as performance-based training. Performance-based training is going to be higher heart rate, shorter duration. You'll also notice, though, when we get to resistance training, this is significantly different than what you would do for performance training. Resistance training for cardiovascular health, lighter weight, higher reps. It is tough for me to define what is lightweight because that's different for everybody. And my general advice is something that you can do 20 times without stopping. That's going to qualify as a lightweight. If you can do that, then that's great for resistance training. We're not trying to build bulk. We're trying to tone and optimize the muscle mass that you have. Again, very different than training for performance. Pretty much in every situation, I'm not going to recommend heavy lifting for cardiovascular health. That's not what we're after. Heavy lifting causes you to bear down with your abdominal muscles. It causes a huge spike in blood pressure. When you do maximum effort lifting, your blood pressure will go to 300 millimeters of mercury systolic while you're in the lifting phase. That's not particularly good for your heart. It's not particularly bad, assuming that you don't have any other risk factors. But if we're going to look at optimal cardiovascular health, again, it's very much different than training for performance. Okay. Weight management. The most important thing about weight management that I want to get across to patients and anybody that I'm talking to about cardiovascular risk is weight management and exercise, while related, are not the same thing. I always, every day, have patients that come in and say, well, I'm going to lose weight. I'm going to the gym. I'm going to the gym. I'm going to lose a bunch of weight. That is not the best way to think about losing weight. Certainly exercise is a component, but exercise, it is hard without changing your diet. It is exceedingly hard to lose weight through exercise alone. We all watch things like The Biggest Loser, where they have participants on there exercising for extended periods of time throughout the day, doing lots and lots of exercise. And theoretically eating less, right? And they have dramatic weight loss. But most of us in our real life can't exercise for 8 hours a day because real life also exists. And so it's just really, really hard to get enough exercise to have enough calorie burn to actually lose significant weight. It's definitely part of it, but it's really hard to do. My saying that I like to communicate with patients is we lose weight at the dinner plate and then maintain at the gym, okay? And ideally, we would like to have a BMI between 20 and 25. BMI is not a perfect measure by any means, but it is the measure that we have. It is easy to calculate. It's the measure, importantly though, that has been used in studies of cardiovascular risk and cardiovascular health. And no matter how you feel about, it's like, well, my BMI is high, but I know that I'm fit and I know that I'm thin. It doesn't appear to matter. If your BMI is high, you appear to be at higher cardiovascular risk. Because we didn't look in any more detail in the cardiovascular health studies beyond BMI. We looked at BMI, we looked at cardiovascular risk and the event rate for patients in different categories of BMI, and it's very clear. The correlation between BMI and risk is very clear. So ideally, we'd like to get between 20 and 25. as you know, most people in America are not between 20 and 25. Even modest weight loss has significant cardiovascular health benefits, has significant benefits in managing hypertension, even 4 or 5 pounds has significant benefit. So, in general, patients that are going to be successful at losing weight and maintaining weight loss are going to be doing it in a manner where you're losing a pound to maybe 2 or 3 pounds per week. If you're losing weight more rapidly than that, it is generally not going to be a maintainable lifestyle. Weight management in the long term is about something that is maintainable, which is the problem that I ultimately have with Atkins and South Beach and whatever else, is that they tend to be not maintainable. You get dramatic results, right? But then eventually you want a piece of bread and you end up gaining all the weight back or more. And so they can be effective, but it's not a maintainable lifestyle. And all the same issues that led to overweight or obesity in the first place still exist. And so when you go back and say, oh, I'm done with my diet, I have achieved weight loss, and then weight comes back. And so, but if you make it a lifestyle and you're having slow, gradual weight loss, and it is a lifestyle, that's likely to be maintainable. Because there's really no point where you feel like I'm really restricting myself. I'm very, very restrictive. It's a lifestyle change, and with that lifestyle change, that tends to be maintainable. It's healthy habits. All right. This is not usually about content. It can be. Dietary patterns help. They play a role. If you're existing entirely on bacon fat, changing to something else will lead to weight loss. But that's not usually the case. Most of us have a relatively balanced diet. The primary issue is portion control. Something very subtle has happened to the size of our portions over the years. I have a dishwasher that's about 18 years old. I bought new dinner plates. The new dinner plates don't fit in the dishwasher, right? So the plate size has gotten larger. We've gotten larger as a country. And the two things are not unrelated. So, it's a subtle thing, but it is about portion control. And that's really the primary issue for most people. Okay, this was not in the overview, but it's kind of thrown in the middle here, not to be overlooked as a risk factor. Tobacco is a huge risk factor. I think, for the most part, I'm not sure. I think people are very aware of the cancer risk and the pulmonary function risk, the lung function risk of smoking. We're very aware of the sort of mouth cancer and neck cancer risk with chewing tobacco. But a lot of people continue to overlook the heart attack and stroke risk of smoking and chewing tobacco. I mean, the bottom line is that to reduce your risk, you have to stop. You really have to stop using tobacco. And when I'm talking to patients that are using tobacco, if I can get nothing else done, if I can get them to stop smoking, that's the single most beneficial thing that I can do for them. So the other question that often comes with tobacco is, well, what about the vaporizers? What about the e-cigarettes? So the bottom line on this is we don't have any idea. It's too new. We don't have any really actual data. The American College of Cardiology and the American Heart Association issued a joint statement saying that we support the use of e-cigarettes, but the caveat in that statement was we support the use of e-cigarettes as a bridge to quitting, not as a way to continue to use tobacco. But ultimately, we don't know. We think that it's related to, we think that the part of the tobacco risk, in addition to the tobacco itself, is related to inhalation of smoke. Because we do see this with other things where you inhale smoke. People that live in environments where they have open cooking fires or other things where they're inhaling a lot of smoke do tend to have elevated cardiac risk as well. And so it's something about inhaling smoke and the inflammation that causes. But e-cigarettes, we don't know. It's probably a different conversation in 5 years when we have actual studies of e-cigarettes. Okay, next, do I need medications? And the answer is, well, it just depends. It depends on what's going on with you and what other medical conditions you may or may not have. Right? So I get basically asked about 3 categories. One is, should I take an aspirin? Next is, what about my drugs for diabetes or hypertension? What about my treatment for sleep apnea? That sort of thing. And then about statins. Okay. So aspirin. Everybody thinks, or everybody says anyway, oh, take an aspirin, it's good for my heart. Why are you taking aspirin? Well, it's good for my heart. Somebody told me I should take it for my heart. Okay. So primary prevention, which is the use of aspirin without a prior heart attack, a prior stroke, or other vascular disease. We do not currently have a strong guideline recommendation on this. Right now, our approach is to assess the use of aspirin in primary prevention based on your calculated cardiovascular risk. The current guideline statement says unless the risk is very high, being greater than 10% risk of heart attack or stroke within the next 10 years, the balance of the data does not support use of aspirin for primary prevention of cardiovascular disease. Can't remember. No, I didn't. There is now data for primary prevention use of aspirin for other things, the most prominent being colon cancer. And so if you do have a high risk of colon cancer in your family, if there's some other concern about colon cancer, then yes, maybe you should take an aspirin a day. However, for cardiovascular disease, without known existing disease, if you want to take it, fine. If you don't want to take it, also fine. But there's no clear benefit. Okay, medications and treatment for other conditions. If you develop other health problems, other than orthopedic problems, generally all other health problems affect cardiovascular health. It's important to try and manage them aggressively. And so working with your primary care provider to manage your hypertension, to manage your diabetes, to manage your sleep apnea, manage your cholesterol. A lot of people, I think, blow off. It's like, oh yeah, I'm always hypertensive. My blood pressure is always high. And it's like, oh yeah, haha, my blood pressure is high. I'm not really taking meds. I'm supposed to be taking meds for it. It may seem like nothing, and particularly hypertension is tough because at least initially in treatment of hypertension, patients often feel worse when we initially lower their blood pressure because their body is accustomed to a higher pressure. But there really aren't symptoms from high blood pressure. The symptom of high blood pressure is a heart attack or a stroke. That's a late symptom, but that's the symptom of high blood pressure. We want to avoid that. We want to try to avoid that. And so we do that by managing those issues earlier. And so I say, they may seem trivial, but they do drive a significant portion of risk. The other one that I often see swept under the rug, I guess is the right answer. So the other one I often see kind of like ignored is sleep apnea. It's like, oh yeah, I'm supposed to use my CPAP, but I don't. And I think, it's kind of promoted as, well, I'm really tired, and so I should use my CPAP, and that'll make me feel less tired. But it's really about much more than that. Sleep apnea if you have untreated or undertreated sleep apnea, it leads to worsened hypertension, worsened chronic inflammation. It increases your risk for heart attack and stroke. It also increases your risk for other cardiac conditions such as abnormal heart rhythms and things like that. So, and almost universally, other medical problems cause increased cardiovascular risk. Okay, so statins. I think this is between this and smoking, I think this is the thing I spend the single most amount of time on in clinic. In the lay press and certainly on the internet, there's a lot of controversy about statins. And I would say that if you actually look at the science of statins and you look at the data that's behind what our current professional society recommendations are for statins, there really isn't controversy. The data are very clear about statins. If you have high cholesterol, it is very clear that if you take a statin to lower your cholesterol, that it reduces your risk of heart attack and stroke. Now, we do still recommend lifestyle measures, even if you are taking a statin, because that dietary and exercise and that stuff also reduces your risk. But taking a statin, if you need it, if you're doing those things and your numbers are still high, then you need to take a statin to reduce your risk further. It's not about the cholesterol number. That's the thing that we measure. That's the marker that we're looking at to determine what is your perceived risk. But it's not actually the cholesterol alone. What we see when we treat with statins is we track the lowering of cholesterol. But again, we're just tracking the marker. So it's not the cholesterol alone that is the risk. It is the cholesterol plus all the other things that are in that biochemical cascade that the statins interrupt. And so, but the cholesterol is the marker. That's the thing that we can measure. The other things in that cascade are much harder to measure. And so that's why we push so hard on statins for primary prevention. It's one of the single best things that we can do. It's kind of stopping smoking and getting people on a statin, and then other things after that. And that's if your risk is high. I try not, I try to express to patients, look, I don't want you to be on a statin. Ideally, I would like you to not be on a statin. I would like you to be able to do this on your own. But if you're not able to, either from genetics or lifestyle or whatever, then we need to help you. And that's what the statins are for, is to help get that down and reduce risk. So the other thing to talk about with cholesterol is that there are other medications other than statins out there that do reduce cholesterol, and there are other natural products out there that do reduce cholesterol. However, with the exception of red yeast rice, which is effectively just a very, very weak statin. It has the exact same molecule that's in the statin pravastatin. It's just a very, very weak form of it. With the exception of red yeast rice, there is nothing outside of the statins that has ever been shown to reduce risk. So they will make the numbers look better, but they do not reduce risk. And so things in this category are niacin, omega-3 supplementation, and ezetimibe or Zetia, which is a different category of drug. They do reduce your cholesterol numbers. And in the case of niacin, it does increase HDL, which is the good cholesterol. But very interestingly, they do not change the rate of heart attack and stroke. So there are additional things that the statins are doing by interrupting that biochemical cascade that reduce risk. And that's really what it's about. There is a minimum amount of reduction in cholesterol that I want to see when I put a patient on a statin, but beyond that minimum amount, it doesn't really matter how much more the number goes down. The lower it goes, the lower the risk is. It's particularly important in patients that are really high risk. I mean, we're not talking about patients that have sort of mildly elevated cholesterol or mild risk being in the sort of 3 to 5% range over a 10-year period. We're talking about those patients that are above 7.5% for a 10-year cardiovascular risk. Those are the patients that benefit from moderate to high-intensity statin therapy. Those are the patients I'm really going to push hard to try and convince them to take a statin. Okay, find my clicker again. All right, so that brings us then to the bottom line. What is my risk? So there's a publicly available calculator from the American College of Cardiology website. It requires a few pieces of information: your age, your sex, your race, your blood pressure, and your smoking status, your diabetes status, whether or not you're on treatment for blood pressure, and and a couple of numbers out of your cholesterol panel. This is the 10-year pooled risk calculator, the 10-year ASCVD risk model for heart attack and stroke. ASCVD stands for atherosclerotic cardiovascular disease, which basically means plaque or narrowing of the arteries. This is currently the best performing risk prediction model that we have. This risk modeling for cardiovascular disease has been being undertaken since the Framingham study, which was done in the town of Framingham, Massachusetts. It started, I think, in the 60s or 70s, and was the first thing to really define what are risk factors for heart attack and stroke. And that was the first model. Since then, there have been several models that have had slight iterations and improvements on the risk prediction. So matching how many people does the model say are going to have a heart attack and stroke versus how many people actually have a heart attack and stroke. And this model does a pretty good job of that. But anyway, you can go to the website, put in your numbers, you can see what your risk percent is. It will also tell you what would your risk be with optimally controlled risk factors. And that's really where we come in, looking at, I've got this person now on a statin, and you can really see for patients particularly that are over 10% risk, you can really see we take that risk from 10% for over a 10-year period down to 2 or 3% over a 10-year period. And that's a significant risk reduction. It really is. That's a lot. But that's the model that we are currently using. As a model we feel is generally the best predictor. Interestingly, you'll note that one of the data elements that's not in there is family history. Family history is an important risk. However, that risk greatly attenuates as you get older. So if I have a 30-year-old, 35-year-old in my office and they say, hey, everybody in my family has had a heart attack before the age of 40 and I'm 35, that person is at very high risk. When you're in the office and you say, well, I'm 67, my dad had a heart attack at 60, that's not adding a lot to your risk. At that point, or if you say, I'm 67, my dad had a heart attack at 90, at that point, your risk is being primarily driven by your age and your other medical conditions. And it's very little to do with your family at that point. So the younger you are, where you would generally be low risk, a strong family history of early heart attack or early stroke does increase your personal risk significantly. However, as you get to be older, the primary risk factor driving it is age and gender, and the family risk becomes less and less important as we get older. Okay, so let's kind of wrap up and then we'll have a fair amount of time for questions. Yeah, good. So the overall message, right? So to reduce your risk, what can you do, right? So maintain a healthy weight. You can eat a DASH or Mediterranean style pattern of eating. You get regular cardiovascular exercise. And again, that's aerobic exercise, 40 minutes of elevated heart rate. Stop tobacco, don't smoke. It's pretty straightforward. And then the thing that I think often gets overlooked, make sure you're controlling your other medical conditions. So make sure you're controlling your blood pressure if it's high. Make sure you're controlling your diabetes if that's a problem. Make sure you're treating your sleep apnea if that's a problem. Make sure that everything else is in line, and that's what you can do. And then you can calculate your risk estimate and see what it is. And I don't know that that's necessarily that interesting as an isolated piece of information, but if you want to know, this is my percentage risk, then you can go put it in. Okay. All right, so questions. Anybody have questions?
If you have a question, just let me know. I'll bring the mic over here.
Can your cholesterol get too low from a statin?
So the question was, can cholesterol get too low from a statin? It's hard to actually make it get too low with a statin. Theoretically, there is some lower limit, but we've found that even with, the part of the cholesterol that we are concerned about with the statins is the LDL, the low density lipoproteins. And even down to around 20. So normal LDL is probably 70 to 100. We consider above 130 elevated, but 70 to 100 is probably an average normal person. Even down around 20, there's no evidence that that's too low for the body. If you got down to zero is not a good number for anything, but. So yes, theoretically, I think you could make it too low, but it's really hard to do that. If you need to take a statin to control your cholesterol, that means it's high, and it's going to be really hard for us to get it very low. Now, that's for patients that have not had a heart attack or a stroke. It's a little different. In some patients that have had a heart attack or a stroke and had very low cholesterol ahead of time, it's tough because we can very clearly reduce their risk by putting them on a statin. And that's been a benefit that's proven post-heart attack, post-stroke. Still putting patients on a high-intensity statin, regardless of what their numbers were ahead of time, reduces risk of recurrence. But sometimes those patients had an LDL of 80, and you really make that LDL number quite low. Right now, at least in the US, our guidelines are treat to dosage, not treat to target. So we're not treating to a target LDL number. There is no current recommendation for a minimum LDL number. Again, most of the time, even if you started at 80 or 100, which isn't technically elevated, and we put you on the most powerful statin that we have, your LDL doesn't usually go much below 25. It's really hard to get it much lower than that. So yes, I think theoretically there is some concern there, but it hasn't really proven out so much in practice.
Hi, I'm interested in knowing about calcium supplements and the effect on your arteries.
So in general, as long as you have healthy kidneys, not that much. Calcium is interesting because calcium is deposited everywhere in the body where there's inflammation. And so there's some thought that, well, if you're taking a lot of calcium, then you're going to get more calcium deposition in the inflammation. In reality, though, the kidney is really very good at managing your calcium. And so it won't really let you get too high. Unless you have some intrinsic kidney dysfunction. So it doesn't seem to contribute to increased calcium deposition. Now, there are other medical conditions that lead to very high calcium in the body. That absolutely leads to increased calcification within the body, right? But that's different than taking supplements. Maybe you could take enough supplementation that you would give yourself a high enough calcium in the blood that the kidney couldn't handle or regulate, and then that would lead to increased calcification. But if your blood levels of calcium are normal, you're not really going to get increased calcium deposition, partly because the kidney's good at regulating it, and partly because it's only going to get deposited in areas of inflammation anyway. So no, I don't. There's nothing that I'm aware of that has increased risk with high calcium supplementation. There are other reasons to not do that, but cardiovascular risk isn't really one.
I just heard it was hard on your arteries that would contribute to building plaque.
Well, calcium gets deposited within plaque. Calcium doesn't build plaque. Calcium gets deposited in existing plaque. So, that's the argument about chelation therapy is that, well, we take all of the calcium out and then they can't get deposited in the plaque. It's like, well, yeah, but the risk is not actually the calcium. The risk is actually the plaque. And the calcium goes in there, and the calcium actually serves to stabilize the plaque a little bit. So, which is why it's getting deposited there by the body, is it's trying to stabilize this otherwise inflamed tissue that has bad potential. And again, chelation is another therapy that's never been proven to actually reduce risk.
You mentioned that statins disrupt the cascade of biochemicals and that cholesterol is just the marker.
Yes.
So what is that marker level?
The cholesterol?
Yes.
You mean like what number are we shooting for? Or?
Yes.
So we're looking at LDL, right? And it's a subcomponent of the total cholesterol number. I look at the total cholesterol because there are conditions that cause you to have a very elevated total cholesterol. But primarily what I'm looking for a risk marker is what is your LDL cholesterol? And then what is your HDL to LDL ratio? Yeah. Although the ratio has had less importance recently. Most of the recent studies have just looked at the absolute number of LDL. So we don't really have now in the US, the European Society has taken a little bit different approach to this, but in the US we don't really have a target number, okay? We do consider above 130 for LDL to be elevated. We would start therapy for LDL reduction if your LDL is greater than 190. And that would be moderate to high intensity statin therapy for an LDL of greater than 190, no matter what else your risk might be. Otherwise, we want it lower. Lower is better. Anytime it's been looked at, the lower the LDL, the better the outcomes. It's the same story with blood pressure. The lower the blood pressure, the lower the event rate. Lower the LDL, lower the event rate. And so, for patients on statin therapy, the lower the LDL, the better. For patients not on statin therapy, lower the LDL, the better. So it's not really an absolute number. So yes, above 130 is considered elevated. Above 190 is significantly elevated and would indicate starting therapy. Between 130 and 190, this is where we use our risk calculator to decide what's your risk, what's your calculated risk. If you're above 7.5%, then moderate to high intensity therapy. If you're below 7.5% with an LDL greater than 130, then low intensity statin therapy and diet and lifestyle. Diet and lifestyle for everyone, really. But.
I have a similar question regarding blood pressure.
Yes.
There've been some different numbers thrown around and what is acceptable and what's too high, or I suppose what's too low.
So there is no minimum number. The minimum number for blood pressure is when you pass out or have symptoms, and that's different for everybody. In general, some people get symptomatic when the top number, the systolic blood pressure, is in the 90s. Other people, it's when it's in the 80s. Other people, it's when it's in the 70s. I can't predict who's going to be what number, but the bottom line is the minimum number is where you're having symptoms. So for my heart failure patients where it's very important to have a very low blood pressure, I say the correct blood pressure is 2 points above syncope or 2 points above passing out. It's a little bit of a joke, but it's as low as I can get it without causing you symptoms. And then as far as what's acceptable for the upper end, well, that depends on what your other risk factors are, okay? We have very consistently shown in all populations, in all demographics, so all age groups, the lower the blood pressure, the lower the risk. So now our current treatment targets. So we will start treatment for the general population when blood pressure is above 140/80. That is liberalized a little bit for patients over age 75, and that target is then above 150/90. After that, you need to be on therapy. So we'll give you a trial. We'll say, hey, do these lifestyle things, limit your sodium intake, exercise, and see if you can get your blood pressure down. Lose weight if that's applicable. Then other things to treat blood pressure as well. Make sure your sleep apnea is managed if you have it. Make sure that everything else is working well. Try to get the blood pressure down. If after 3 months you're not able to do that, then it's time to start medication. I didn't talk about it, but sodium intake. We've really changed our guidelines as far as dietary sodium intake recently. Anybody with hypertension, we're trying to limit to less than 1,200 or less than 1,500 milligrams of sodium per day, which is incredibly low. It's like a quarter teaspoon of salt. That's not very much. A single burrito at Chipotle has 1,200 milligrams of sodium in it. So, in America, we have a huge problem with way over-consuming sodium, and it really drives a lot of our hypertension problems. And the issue is that we get used to foods that are very high in sodium, and that tastes normal to us, and then when you have something that's low sodium, it tastes very bland. However, if you decrease the sodium very gradually, your taste buds don't catch on, and then all of a sudden you're eating a low-sodium diet and you don't taste the difference because your taste buds kind of recalibrate. And then if you get something that's high sodium, like you used to eat, it tastes really, really salty and not good to you. So it's tough. If there's not an emergency for some reason, I'll try to get people to limit their sodium intake, and I'll say, hey, just decrease it. Decrease it gradually. Don't try to go immediately to a low-sodium diet. You're unlikely to stick with it because it'll taste terrible. But if you gradually pull back, you'll be able to do it, and you won't be as offended by the dietary changes.
Along the same lines, what role do you think sugar plays in the whole scheme of things?
The question was what role does sugar play in the whole thing? So sugar is not really a direct risk factor for cardiovascular disease. Sugar is a risk factor for diabetes, which is a risk factor for cardiovascular disease. Sugar is a risk factor for overweight and obesity, which is a risk factor for cardiovascular disease. So it's not the sugar itself. Sugar itself is good for you. It's how much you're eating, right? And so as with all things, it's really portion control. And so, there's nothing wrong with sugar. There is something wrong with, a soda full of sugar or 5 sodas a day full of sugar. That's going to be too much. That's going to lead to problems. But there's nothing intrinsically wrong with sugar. It's the amount that you're taking in.
How, is there a way to determine whether you have sleep apnea other than through a sleep study? Are there some symptoms that you should kind of look out for?
Right. So it's easier if you sleep near or with someone in the same room because you ask them, hey, do I ever stop breathing? They usually know. Sometimes they don't, but if you're sleeping with someone, they usually know. They usually have an idea. It's like, yeah, I have to kick you because I'm afraid you died. And so that's one way to say. And if they answer, yeah, you stop breathing all the time, then you need to get a sleep study. If in the absence of that, if you're known to be a very loud snorer, that's a risk factor. If you have excessive daytime sleepiness, like you sit down and just immediately fall asleep, or you're just kind of always feeling fatigued, that's a risk factor. If you have a very large neck, if you have a receding chin, if you have a very small opening at the back of your mouth, those are all risk factors. But there's no guarantee. I mean, when a patient comes into the office, I can usually look at them and get a sense for their neck size and have a pretty good idea of, are you at risk for sleep apnea or not. But there are a lot of people that fall outside of those norms and either have sleep apnea without a lot of the traditional risk factors, or are the picture of sleep apnea. If you look it up in the dictionary, sleep apnea is like this picture of this person is there, and they don't have it. So. If there's some suspicion, you get tested. And so there are 2 ways to do it. You can do a traditional sleep study where you come in, you sleep in the hospital. There are other options available. You can do an overnight oximetry just to see if your oxygen goes down while you're sleeping. Because usually with sleep apnea, when you have the moments of apnea, which is not breathing, your oxygen goes down. So you can do overnight oximetry. And then there are some at-home devices. I don't know, I haven't seen them be used here. They're a relatively new thing, and they're kind of finicky based on insurance as to not whether they're covered. And so there may have been some coverage decisions in Montana that have not had them be used here. So there are a couple of options, but the gold standard still is the sleep study to actually figure it out. We can say, are you high risk? Are you intermediate risk? Are you low risk? But ultimately, if there's a question, just do the study and find out. It's one night. It's not a huge deal. There is some cost associated, but it's not a ridiculous number. We certainly do a lot of things that are way more expensive than that. Okay. All right. Good. Thank you very much.